You, Andrew. I appreciate having you and Greg give me this opportunity to spend a few minutes with you. First, a little disclaimer. My undisclosed location is Alexandria, Virginia, right across the river from Washington, D.C. I thought I was going to be in my office doing this presentation. Fortunately, we had some internet issues, so I'm actually out in this common area. So I apologize if there's any kind of echoing here and if there's any ambient noise during the presentation as someone's walking by. Unfortunately, that's what we're going to have to deal with. It's obviously a busy time here in the DC area and in the country. We're obviously only a few days away from a midterm election. I'm sure depending on what state you're living in, you're being inundated with political commercials. If you're in some other states, you might not even be aware just based upon whether or not there's competitive Senate elections going on. It's obviously a very tight election. If you've been paying any attention, the control of both the House and Senate is up for grabs. We have obviously a 50-50 tie in the United States Senate, with Democrats controlling because of Kamala Harris, the vice president, being able to break that tie and give the Democrats operating control in the Senate, though obviously that's very tenuous. And that very close margin makes it really hard for the Senate to pass legislation. In the House, the Democrats are hanging on to a very small majority. And I think most prognosticators looking at the election coming up see a pretty strong built-in structural advantage for the Republicans to assume control of the House on election day. Though again, there's some big issues at play, both, some in favor of the Democrats, some in favor of the Republicans, that I think have pollsters a little bit confused and a little bit concerned about, how accurate their polls are. So I think it's really impossible to say at this point what kind of what we're going to look at in terms of a political structure for 2023 and 2024 going into the next presidential election. That said, I will tell you that because of the upcoming election, Congress is obviously out of session right now. To date, they have not been really focused on a lot of healthcare issues. That has not been a priority, and you're not hearing about that much on the campaign trail. There is obviously the possibility that after the election, they will come back and have a lame duck session, which is generally a little session they have after the election, but before the new Congress takes office, where they try and clean up some business and get some things done. And sometimes, because you're in that post-election environment, you have everything kind of settled. Things are a little calmer, and it's a little more possible to get the Republicans and Democrats to agree on some common issues and pass some legislation to get it to the president. So if indeed there is some kind of lame duck package of, an amalgamation of different pieces of legislation that everyone can agree on, we're going to look to that as an opportunity to obviously try and see if we can get something that helps ASCs added to that package. But probably getting a little bit ahead of myself here because we're not there yet. We don't know. But I think when I get a little bit later in this presentation and I talk about our legislation and a couple of the provisions, I think I'll be able to identify, the one that I think, if we do have that opportunity, we might be able to try and get added to some last minute package and hopefully signed into law. But first, I suppose the elephant in the room, of course, is our Medicare payment rule. For those of you who kind of know this process, every summer on or around the 4th of July, the Centers for Medicare and Medicaid Services releases our proposed payment rule for the following year. So the rule I'm talking about will impact 2023 and actually take effect on January 1, 2023. And the process is that proposed rule is released, as I said, on or about the 4th of July. We have until about mid-September to review the rule, which is generally 1,000 to 2,000 pages long, and includes regulations that are going to impact not just ASCs, but also hospital outpatient departments and other providers in a number of ways. That comment period closes in mid-September, and then the final rule is supposed to come out on or about November 1 to give us 2 months to be able to implement whatever changes on a regulatory standpoint are included in that final rule. So when it comes to the proposed rule, all I can speak to at this point still is the proposed rule As I said, we're about a week away from getting that final rule. But I quite honestly don't expect dramatic changes from the proposed rule to the final rule. Rarely do we see a lot of significant differences. Hopefully, though, our advocacy and the lengthy comments that we provided to that rule, as well as maybe some of you did, will see some changes that will be beneficial to the ASC community. First and foremost in the rule, and the thing that's usually top of mind when people are thinking about that rule, is what kind of inflationary increase are ASCs going to get for 2023. We were all, I think, really disappointed to see that in the proposed rule, they are recommending only a 2.7% inflationary update. And it was 3.1%, but there's some budget cutting that goes on in that process. So the 3.1 becomes 2.7% in the proposed rule. Now that's on average, and obviously that changes for given procedures and based upon where you live in the country. But clearly, for those of us who've been, going to the food store this year, inflation is much higher than 3.1% or 2.7%. And so we're obviously very, very disappointed in that very meager proposed inflationary update. And so one of the things that we spent a lot of time in our comment letter talking about was the obviously tremendous increases that ASCs are experiencing in terms of paying for salaries, paying for devices, paying for supplies, and that what we're paying for those things is far outpaced the inflationary impact of 2.7%. Now, the one good thing is that we are still being updated for inflation using the the hospital market basket, which is an inflationary factor that is applied to both the hospitals and during this pilot period to ASC. So we're being tied to the same inflation factor as the hospital outpatient departments. And the value there is obviously the hospitals are every bit as disappointed in that 2.7% proposed update. So we have them lobbying and commenting along with us to try and get that inflationary update increased. So if I was going to provide any kind of hope about that, earlier in the year, the inpatient hospital rule came out, and that proposed rule had a lower inflationary update than was actually included in the final rule. And it is actually pretty normal for CMS during that period from when the proposed rule comes out until the final rule comes out, for them to continue to look and monitor the inflation factor. So I think there's some possibility that we could see an increase next week. I'm actually very hopeful that we will, but obviously I can't promise that. This, as I mentioned, is the last year of a 5-year pilot where we are being updated on that hospital market basket along with the hospital, something that I think has been really valuable. And as I mentioned earlier, aligns us, at least in terms of our advocacy, on trying to get the most proper inflationary update each year. That 5-year update pilot was proposed during the prior administration. We obviously don't know whether or not the current administration is going to want to finalize and include, keep us on that hospital market basket. It's something that we're obviously lobbying very hard for. In fact, one of the things we're arguing for is we think that even that 5-year pilot needs to be extended because of the pandemic and the impact it's had over the past few years in terms of data collection at CMS. And that if they really want to see the positive impact of keeping us on the same inflation factor as the hospitals, they really need more data. They really should be extending this pilot for a couple more years. But again, that's something that we're going to have to be working really hard on next year to make sure that we don't end up back on the prior inflation factor, which was the consumer price index for urban consumers, or even another inflation factor, which might even spit out an even lower number. Because one of the things that we have obviously been very concerned about, one of the reasons we've articulated why we need to be on the same inflation factor as the hospitals, is we're already being reimbursed so much less than that. And if we have divergent inflation factors that leads them to get a larger inflationary update than us in any given year, that's just making that delta between what we're reimbursed and they are even greater, and making it less likely that we're going to get more care migrated to our space and save, obviously, the Medicare system billions of dollars. So that's something that we're going to be paying very close attention to, and something that I hope all of you will help to lobby with us on with the agency as we go into next year's rule period. The other big area in our proposed rule that we always look at very closely is what procedures are being added to our payable list. As most of you are probably aware, we have a very distinct list of procedures that Medicare will reimburse us for in terms of performing on Medicare beneficiaries. And that list is smaller than the list of what can be performed outpatient in the hospital outpatient department. And then, of course, there's still a separate, distinct inpatient-only list, procedures that can only be performed on Medicare beneficiaries as an inpatient procedure in the hospital. You may recall that in the last year of the prior administration, there was an effort to try and do away with some of those distinctions, to do away with the inpatient list completely, and then to greatly expand our list. Last year, in the first rule of this administration, the Biden administration, a lot of that was clawed back. And I think clawed back quite unfairly, because I think that there was a lot of evidence to show that ASCs can be safely performing many more procedures on the appropriate Medicare beneficiary than we're currently allowed to. All that said, that leads us to where we are with this proposed rule, which is a very disappointing, only one new procedure being proposed to our payable list. And it's actually an ENT procedure that, quite honestly, is not of significant impact to the ASC community. And we believe that, we had proposed 47 distinct procedures, some which included procedures like total shoulder and total ankle, that we know are being safely performed in the ASC space on commercial patients, and particularly commercial patients at or nearing the Medicare age. So we really think that CMS has missed a great opportunity by not providing more procedures to our list, because we know that obviously we can safely perform that on appropriate patients, and in so doing, save both the beneficiary and ourselves a lot of money. So that's something that we obviously push back for in our comment rule, and something that we really obviously hope that they will heed and add those procedures to our final list. So that's something to look for when the rule comes out next week. Related to that is a really, really disappointing element that was kind of baked into that discussion in the proposed rule about our procedures. And we saw this first pop up last year in the proposed rule, and it turned up again. And what that really involved is that the CMS medical directors making reference to their decision-making process for moving procedures to our list, and basing that decision on the impact of how that procedure would be performed on the typical Medicare beneficiary. Now, that is nothing that has ever been contemplated before. And indeed, there is no definition of what a typical Medicare beneficiary is. And indeed, the ASC model is not based upon providing care to the typical patient. It's based upon being able to provide care to the appropriate patient who can be seen safely outside the hospital at an ambulatory surgery center. And so to introduce this concept of a typical Medicare beneficiary, of which you can find no definition in either law or regulation, is really wrong, and something that we really have pushed back on, because if they use this kind of false narrative that for a procedure to be performed in an ASC, it has to be safe for the typical Medicare beneficiary, that is a false standard that we think we shouldn't be held to. So that's something we've pushed back very strongly on. And again, if we still see reference to that in the final rule, it's something that we're going to have to, again, work really hard with to convince them of the error of their ways, because that is not a recipe for moving procedures to our space. And I think, again, who's going to lose by that is not just the ASCs by not getting that volume, but it's the Medicare program trapping too much care with safe, healthy Medicare patients having to get care in the hospital outpatient department at much higher cost to the Medicare program and to we as taxpayers. So that's something to keep an eye on. The final aspect of the rule that I think I'll just touch on is on the quality side. One of the things that we've been quite proud of over the years is that the fact that we now have a quality reporting program where ASCs are providing data to the government on the quality of care that we're providing to Medicare beneficiaries on a number of different procedures and obviously on a number of different potential adverse events. And we obviously have shown outstanding results on both fronts with our quality reporting program. And it's something that we think has been, really helped us to kind of change the perception of policymakers and the health media about the quality of care that's being provided in ASCs over the last decade. One of the things that was finalized in last year's rule, however, was a new measure that we believed was wholly inappropriate to be applied to ASCs, and it had to do with measuring the visual function of a cataract patient. And the concern we had with that rule, and it's something that we have kind of been very wary about over the entire length of our quality reporting program, is to try and make sure that the quality measures that are applied to us are actually facility level measures that look at the quality care being provided in the facility and where the data about that procedure or that measure is held within the surgery center. And the problem with this visual function measure is it's actually a physician level measure. It's actually included in the physician quality reporting program, though little used. And the problem for us with having a visual acuity measure to have to report on is, well, the initial establishment of the visual acuity of that Medicare patient is done in the physician office, not in the ASC. And the post-visual function analysis is done again in the physician's office well after the procedure having been performed in the surgery center. So on both ends, the data that we were being asked to report on, we didn't have. So we pushed back after that rule. Well, obviously when that rule was that measure was proposed, we pushed back after it was finalized, and we're very pleased to see that in the proposed rule, they've actually recommended withdrawing that measure. So we're obviously hoping and pretty confident that in the final rule, we're going to see that measure has been withdrawn because we don't think it applies in our program. In the few minutes I have left, I want to obviously move over from our regulatory process. And again, next week, that rule should come out, and we'll be hopefully first to market with sharing the information, good or bad, what is in the final rule. So you'll hear about that as soon as it happens. We also have legislation. So I started off with, has not been a lot of activity on the legislative front from a healthcare perspective this year, particularly as it pertains to surgery centers. But we do have our legislation that has been introduced in both houses of Congress. We're very proud of the fact that every year we get, or every cycle, we get our ASC legislation introduced in both the House and Senate. And we've worked very hard to make sure that we have both Republicans and Democrats as co-sponsors of our legislation. We're very proud of the fact that the things that we're arguing for and lobbying for are bipartisan and are things that both Republicans and Democrats, liberals and conservatives can support, because all our legislation does is trying to improve the quality of care of the Medicare program, create greater access to ambulatory surgery care for Medicare beneficiaries who belong to be seen there, and obviously leads to Medicare savings in the billions, if not tens of billions of dollars. When we think about our legislation, there's a number of provisions. I really just want to highlight two. One of which is a very complicated budget mechanism referred to as the weight scaler, which is a budgetary mechanism that CMS uses to establish our reimbursement rates each year that dramatically undercuts what we should be reimbursed. And the way this works is that, and it's very complicated, but CMS actually has to keep each program budget neutral, meaning other than the inflationary update, they try and control costs, and they do that in silos. So they look at the cost of care being provided in the inpatient hospital space, the outpatient hospital space, home health, ASCs, and look at that in different silos. The problem is for ASCs is we do not have our own payment program. We're paid a percentage off of the hospitals. So as a result, that budget calculation to control for inflation and beyond inflation to keep us budget neutral is made twice for us. It's made once with the hospitals, and then when they're establishing our payments, they do it a second time. So we're in fairly updated, our payments are updated less because of this wage scaling. It's something that really has to be addressed if we're ever going to really try and grow our reimbursements and get paid fairly for the things that we're doing for Medicare beneficiaries. The second provision I just want to touch on is another one that's really perverse, which is that for hospital care, a beneficiary has a copay cap. So if you go in to get a total knee performed in the inpatient hospital or the outpatient hospital, and that procedure costs $25,000, regardless of that cost, you can pay no more than $1,600 this year as a copay for that procedure. Normally, there's a 20% copay. There is no copay cap for procedures in the ASC. And so this leads to the really perverse disincentive where a Medicare beneficiary will look at the cost for her of getting care in the ASC and the hospital outpatient department. And even though the cost of that procedure is half of what it would be in the hospital outpatient department, for the beneficiary, it's going to cost her less to get the care in the more expensive setting because she has a cap on her copay in the hospital outpatient department and not in the ASC. That obviously is perverse, makes no sense, and leads to bad decision-making that's only costing us as taxpayers more money. So that is something that we really need to get addressed. So we have a provision to actually give us a copay cap. So that copay cap would apply in the ASC setting as well as the hospital. So the Medicare beneficiary no longer has a perverse disincentive to go to the lower cost setting of care. This is a provision, by the way, that when we talk to any lawmaker as we're trying to get them to sign on our bill, their eyes go wide open because this makes no sense. Now, to be fair about it, when this copay cap was initially established for the hospital, ASCs were not performing high-cost procedures like total knees or spine procedures. So I think there wasn't a contemplation that a patient going to an ASC would ever need a copay cap. Well, clearly, that's no longer the case. With the more complex cases that we're now able to safely perform, we need this copay cap. And this is something that, I think has to be done sooner rather than later. So as I mentioned earlier, if there is indeed some kind of like lame duck package or an opportunity to insert a piece of a provision into that legislation that would benefit ASCs, that copay cap is probably the most attractive one. It's the easiest one for a lawmaker to understand. It's one for which really there is no sound argument to oppose it. So that's the one we would be looking to get included. I only have a minute or two left. I just want to build off of something that Andrew mentioned, which was the fact that advocacy is so important that we need all of you to actually be talking to CMS, talking with your lawmakers at both the federal and state level to make sure they understand what the ambulatory surgery model is, the value that we provide, and the savings that we're providing, both on the commercial market as well as in government programs like Medicare or Medicaid. You all need to be advocates. We have plenty of opportunities for anyone in the ASC community to help us out in this advocacy. If you're at an ASC, we would love you to do a facility tour of both your federal and state lawmakers so that you would get to see the high quality of care providing and the setting that you're providing that care in. We can help you out with doing that. We have a Washington fly-in scheduled for the first time in a few years because of the pandemic. It's coming up at the very beginning of March, I think February 28th, March 1, here in Washington, D.C. You can find more information about that on our website. But we would love for you to come to Washington, meet with your lawmakers and their staff, and talk about the great quality of care that you're providing. Finally, Andrew talked about, supporting your state association. I would tell you the same thing applies to ASCA. If you're not a member of ASCA, please consider joining. I think that when you see all the great things we're doing on your behalf, you'll want to help us out. Membership is not very expensive, and you get a host of great information and services that I think help you run a better surgery center. Same thing with your state association. Your state association generally is much smaller than ASCA. They are trying to, argue for, positive legislation and regulations on the state level against a very powerful hospital community in each state. We need you to support both your state association, ASCA, if we're going to be able to try and make the changes that we need on both the regulatory and legislative front to allow the ASC model to provide the care that it safely can to all the patients that can be seen in a surgery center in this country. And if we can find a way to do that, we're going to save our healthcare system billions and billions of dollars, and just really help us out a lot. So with that, Andrew, I think I've exhausted my time. I thank you for giving me this opportunity, and hope you have a great rest of the day with your conference.
Well, Bill, before we let you go, because you have a couple more minutes, I just wanted to ask you off-the-cuff questions, if that's okay.
Sure.
A couple of years back, there was all this bad press. I think it was USA Today, and really articles about ASC safety, which were absurd journalism, in my view. Has that died down, and how did it die down, or is it still going on?
It died a quick and painful death. Looking back on those days, there was, I think, in the eyes of Kaiser Health News and USA Today, this thought that they had found this hot button healthcare issue, and they were going to, run article after article about the quality care of surgery centers. And I think they quickly found out, because of our advocacy, and I think the advocacy of a lot of others, that there was no there, that they were making things up. They were making false accusations about the quality of care, refusing to, that they were cherry picking a handful of very tragic events. And so that series died a quick and painful death. We've heard nothing about that ever since. So I feel really, really good about the advocacy we perform there. And again, it goes back to the quality reporting and the data that we produce that shows that we are providing great care all around this country.
Okay. Another question, because it occurred to me when I was listening that you might have a similar problem that our law firm happened. So many years ago, I think ASCs and hospitals were diametrically opposed. Now we see so many hospitals, including the hospitals that are joining our panel later this afternoon, who own into ASCs. How is that how does that affect your advocacy? And are you seeing the same trend nationally, where that they've decided they need to be part of the game, hospitals need to be part of the ASC game, and so the animosity and conflict seems to be dissipated?
Yeah, I think it's a mixed bag when it comes to that. You're absolutely right. I will tell you that some of the largest hospital companies in this country are actually members of ASCA, because they obviously have substantial ASC lines. And so I think that has changed. That's a dramatic change that I've seen in the 12 years that I've been in ASCA. I think that it's a mixed bag, though, about whether or not that the fact that hospitals obviously partner, joint venture, or own ASCs has led them to become advocates for the ASC model. I think that's still in transition. I think there is a lot of muscle memory to oppose ASCs or to not think about ASCs as they're conducting their own advocacy. So I think we have work to do there, but I think there clearly is a greater understanding and hopefully greater alignment of interest, as I mentioned with the inflation factor as one example, but other ways where I think that going into the future, hopefully we can be better aligned. Right now, I think there is still a belief in too many hospital CEOs' head that any care that leaves that hospital building and goes somewhere else is bad. And I think we have to change that mindset. And to give you like a horrible anecdote, during the pandemic, I had one of my members who's in joint venture with the hospital talking about the fact that, during that pandemic, when there was a thought that hospitals were going to have to offload care to ASCs in order to provide more care to COVID patients in the hospital, her quote was, "I think my hospital would rather put a tent up in the parking lot and provide outpatient surgery there than send those cases to the surgery center they're in joint venture." That mentality has got to change.
Right. Well, but I also saw those examples, but I saw amazing examples of hospitals turning to ASC saying, "You got to help us," and ASCs converting over, like say a GI ASC that suddenly is treating COVID. And it was like a beautiful thing. And I was hoping that that might have helped along.
Well, I think that those examples, and for example, the little used, but I think really important Hospital Without Walls program that CMS pushed out during the pandemic to allow ASCs to act as hospitals, I think provided evidence, hopefully to policymakers and to the hospitals themselves, that when you look at the staffing in an ASC, you look at the equipment in an ASC, we can do so much more than we're currently allowed to. And that if we can find a way to crack that code, we're going to be able to provide so much care in this country at lower cost and really help out, our healthcare system.
Right. All right. One more. Sorry to keep doing this to you, but it's interesting. You can think on your feet. The new, I'd say going back 10 years ago also, if I said to you, what do you think about private equity owning ASCs? We have some presentations which will touch on private equity's, I wouldn't even say entrance, dominance at this point in healthcare. You would have said, what are you talking about? Now, I don't think you're going to have that. So from kind of a national perspective, what thoughts do you see about it, the pros and cons of private equity owning into ASCs?
Look, I think that something that has allowed the ASC model to prosper and to grow, you again, just the correction I made at the beginning, that we now have over 6,000 ASCs compared to where we were, 5-10 years ago. I don't think that would have been possible without access to capital. And so I think venture capital has obviously provided ASC owners and management companies with the ability to upgrade ASCs, to build ASCs, to expand ASCs into new service lines, whether it's orthopedics or now, cardio, at a greater pace than otherwise would have been possible. So I think that's very beneficial, particularly so long as the ASC model is still efficient and still is fundamentally the lower cost alternative to hospital care. So the only con I can see is if the expectation from those capital investments is a return that diminishes that the ability of the ASC to be the lower cost provider in the marketplace, because essentially the aims of the ASC is to be more customer friendly, a nicer environment for a patient to go, a safe place for the patient to go, and a lower cost set of service. So as long as we are able to maintain that, I think venture capital dollars and access to that investment is beneficial.
And so where does the typical management company, where are they in 5-10 years if you had to guess? Because you have the hospitals that oftentimes think that they can manage themselves, the ASC. You have the private equity groups that oftentimes say, we have financial expertise and stuff, and we don't need the management company. And so what happens? Like, if you had to, what's your crystal ball, or where do you think that ends up?
Well, I think that for again, looking at the ASC model, what makes it run obviously is an understanding at the closest level to the operation of how to run efficiently. So that's obviously the surgeon owners and the administrator who have their eye completely on the ball about keeping the place efficient. I think the management company is probably the next closest element to that in terms of understanding how to run an efficient surgery center and how to keep the model operating the way it should. The further you get away from that, I think the less the less closely you're able to control those elements that make the ASC model work. So that's where I think whether it's having a good surgeon owner team on an independent ASC or a good management company involved in the ASC operation, I think both those elements are really, really critically important if you want to keep the ASC looking like an ASC and not just becoming another version of a hospital outpatient department, where I think that we've seen historically, there's less able to control the time blocks, to control the cost, to control, just the efficiency of the operation. Does that make sense?
Yeah, it does. This is fascinating. So I could talk to you all day, but we have our next presentation. So Bill, thank you always for being such a supporter and doing the good work you and your association do.
Well, thank you, Andrew. Thank you for support of ASCA and the state associations. We appreciate it, and I hope you have a great conference.
Our pleasure. And so the next presentation would be current state of healthcare transactions. Miguel, take it away. Thanks, everyone.